kindly introduce. I already introduced the speaker.
Good afternoon.
Over to you, Dr. Sumita.
Good afternoon, everyone. It's my pleasure to present here the last case of the day and the last case of this entire session. So this is case 6. So this was the history provided to us when the biopsy was sent. The 49-year-old gentleman, he actually presented to the cardiology OPD with shortness of breath, pedal edema and proteinuria. So again referred to the nephrology for further workup. Known hypertensive with coronary artery disease, non-diabetic, the BP was normal on medications. The clinical diagnosis was made as nephrotic syndrome for evaluation. The lab findings, serum creatinine had a steady rise from 2.45 milligram per deciliter to 3.42. Blood urea was 56. Urine spot protein creatinine ratio was also raised to 5.83. And the urine sediment was active. So this is the core of biopsy we received, single linear core. It had almost 9 glomeruli and 1 artery. In this magnification, which is 0.8x, we can actually not see much, but at least we can appreciate that there's not much of inflammation. That's here in between. It doesn't look as blue when the interstitium shows a lot of inflammation. This is a PAS section. We lost a bit of tissue here. So in between PAS, we can see some mild patchy atrophy, tubular atrophy. So higher power view in the HND stain section, this is a sclerosed glomerulus. Another glomerulus which appears unremarkable with no increase in any cellularity, crescents or any peripheral segment of sclerosis. This glomerulus here shows, oh, I'm not getting a pointer. Sorry, I'm not getting a pointer here. This one? ये वाला?
No.
ये नहीं ले रहा है. अच्छा.
Just a minute. ये क्या हो? Laser point. एक मिनट थोड़ा side हो जाना.
Yeah. Thank you so much. So here we can see this is a sclerosed glomerulus, a glomerulus which appears unremarkable, and another one here which shows a peripheral small segment of sclerosis of the tuft. Another glomerulus in HND again, which shows increase in mesangial cellularity. This is a PA stain section which shows 2 glomeruli here, one showing a small peripheral segment of sclerosis and a bit of hyalinosis here. This is another glomerulus which shows a segmental fibrocellular crescent, and the underlying tuft that shows a sclerosis. The proximal convoluted tubules here, they appear unremarkable, a bit of atrophic tubules in this area. By and large, the tubular interstitium doesn't show many changes here. So here all the 3 sections, the same glomerulus which showed the crescent here. This is a silver stain showing the same. So by this time, a nephrotic, a gentleman, 49-year-old, nephrotic presentation with FSGS in my light microscopy and some increase in cellularity and a single fibrocellular crescent was actually not thinking of much more than an FSGS. But when I went ahead with the immunofluorescence study, I recognized that there was diffuse significant linear staining of IgG with no light chain restriction. C3c was trace and IgA, IgM and C1q were negative. So here we can see it's a significant positivity. It's a 4+ positivity on a scale of 0 to 4+ when we score the immunofluorescence. And it was non-granular. It was linear, smooth positivity. So the diagnosis given was focal segmental glomerulosclerosis along with focal segmental fibrocellular crescent, segmental fibrocellular crescent in one of the glomeruli, significant linear staining of IgG in immunofluorescence study with mild chronicity. In view of linear IgG staining, advised correlation with serum anti-GBM antibody. In case of a negative serology, atypical anti-GBM disease should be considered. I had mentioned here in case of a negative serology because it was actually not a classical anti-GBM presentation on my light microscopy also. So this was something I was expecting that possibly this might turn out to be negative by the conventional assays. Some cases have been found in the literature to be ANCA positive, so an ANCA correlation was also suggested, and in view of the nephrotic protein, an electron microscopy was suggested. So when I discussed the case after the IF and the reporting, I discussed the case with the nephrologist and asked for is there any evidence of alveolar hemorrhage. It seems the patient did not present initially with hemoptysis, but later in the week of admission, the patient developed hemoptysis. And when they went ahead, as advised, when they went ahead with anti-GBM and ANCA, both were found to be negative. Patient 2 days back, when asked for follow-up, the patient is actually doing well after 13 months of diagnosis of this disease. The patient hasn't had any renal emergencies or taken to the nephrology department. He's on medications. Initially, he was treated with high-dose corticosteroids. Plasmapheresis was not done. So when the anti-GBM was negative by the conventional assay, it was actually suggested to go ahead and do the anti-GBM serum levels with other assays, but apparently the patient could not afford and they didn't go ahead. So briefly about the anti-glomerular basement membrane disease, it's a generic term for any clinical expression of disease caused by anti-GBM antibodies. Could be the good pasture syndrome, where we have both the lung and the pulmonary the lung and the renal